that, I will say thank you so much for coming. If you have questions, please, you can put them on the chat. But also, if you have something at the end, we will have an opportunity for people to ask questions. Again, my name is Jeffrey Sayantet with the Bitendo for Africa. We always try to bring information and resources that will help our community to be more proactive on every aspect of life. And with that, I will invite Sally to take it over from here.
Thank you, Jeffrey. And yeah, we'll just have Dr. Toriola start us with the presentation. And then after that, I have a few questions to ask, and then we'll also open out to the audience to ask questions.
Fantastic. Good evening, everyone. Great to be here giving this talk this evening. This is very timely, given that there is an explosion of interest in this space. And I think it's really great to know what the challenges are, what the opportunities are, and how to really engage in this space so that we can help move the science forward. So I'm going to be talking about multi-cancer detection assays, also called multi-cancer detection tests today. Can you hear me? Can you hear me clearly?
Yes, we can.
Okay, good. So why are we interested in cancer prevention? This year, over 2 million people will be diagnosed with cancer in the US. Almost 1.1 million males and almost 1.2 million females will be diagnosed with one cancer or the other. That's a lot. Also, this year, over 600,000 people would die from cancer. And as you can see, in male, prostate cancer is the leading cause of cancer, over 31% of cancer cases, followed by lung cancer. With females, breast cancer is the leading cause of cancer, and lung cancer is the second leading cause of cancer. In both male and female, lung cancer is the leading cause of death. So again, this shows us why it's important to really understand how to catch cancer early in order to prevent. What is even most worrisome is that over the last few years, we've seen a rapid rise in cancer cases in women or men diagnosed before age 50. Before, cancer risk increases with increasing age, but like I mentioned, over the last 20, 30 years, we've seen an explosion in the number of cases, cancer cases diagnosed in younger people. And this is really, really worrisome. Most of the screenings that we have do not cater for young people. So the question is, how can we mitigate this rising incidence and also ensure that everybody who is at risk of cancer actually gets the screening they deserve? So why is cancer screening important? Cancer screening is one of the ways that we can mitigate the burden of cancer. Screening is important because screening prevents some cancers. For instance, colonoscopy, one of the screening tests for colorectal cancer, the doctor can use an endoscope, look into the colon and rectum, and if they find polyps, which are precancerous lesions, they can remove the polyps at the time of screening. So colonoscopy is dual edge. It's just for screening. At the same time, it can be used to remove potential cancer-forming substances. Catching cancer early saves lives. If cancer is caught early, the survival is very, very high. Breast cancer, if it's caught at stage 1, 99% of patients who are caught at stage 1 are alive at 10 years. If it's caught at stage 4, only 32% of patients diagnosed at stage 4 are alive at 4 years. So it is really, really crucial to catch cancers early. And that's one thing screening helps to do. Screening prevents more deaths than treatment. A very big analysis done just a few years ago looking at cancer deaths in the last 30 years in the US shows that screening and prevention contributed to 80% of the reduction in cancer deaths over the last 30 years. And treatment only contributed about 20% to the reduction in death. This is not saying that treatment is not important. We've made tremendous advances in treatment over the last 30 years, but the impact of screening and prevention have been more marked compared to the impact of treatment. Screening helps us to detect cancers early. If you detect cancer early, you pick up the less aggressive form of the cancer. That means your treatment will also be less aggressive. It reduces healthcare costs. If cancer is picked up early, that means the patient doesn't have to go through barrage of radiation, chemotherapy, surgery. Patient may just have to go through one of the options. So the individual cost to the patient is much smaller, and also to the healthcare system in general. Also, when you do your screening test and there is no cancer, it just gives you, peace of mind. It helps you to improve your quality of life, knowing that at least so your next screening exam, there's nothing to really worry about. Unfortunately, despite the massive advances and technology advances we've had over the last 50 years, there is only screening available for only 5 cancer types. We have over 100 cancer types, but we only screen for 5 cancer types. And that's because these are the only 5 cancer types where there is evidence that screening works. Before you institute screening programs, you have to have rigorous evidence, because screening has its benefits and harms, and you want to be sure that people take mainly the benefits and the harms are reduced. So yeah, it's appalling that we have screening available for only 5 cancer types. The first one is breast cancer. The screening test for breast cancer is digital mammography or breast tomosynthesis, depending on the individual. For cervical cancer, the screening tests are pap smear or HPV testing. For colorectal cancer, we have both stool-based tests such as FIT or DNA test, or now Cologuard, or colonoscopy, which is an imaging procedure. For lung cancer, we have low-dose CT scan, and for prostate cancer, we have PSA test. So these are the only 5 cancer types to date that you can screen for and potentially pick up early cancers. The really exciting news is that when you screen, you can really prevent deaths from cancer. For instance, screening for cervical cancer has been attributed to preventing 100% of cervical cancer death. Screening for colorectal cancer is responsible for preventing 79% of colorectal cancer deaths. The number reduces a little bit for prostate cancer and breast cancer, where screening contributes to reducing 56% of prostate cancer deaths and 25% of breast cancer deaths. However, I like this cartoon because we know that screening can be very challenging, and there are several reasons why the current modalities of treatment of screening can be very challenging. And that's why not everyone who is eligible for screening undergoes screening. We know there are several factors responsible, from socio-demographic factors to several reasons, lack of financial reasons, and just getting the time to actually go for the screening. Right now, as of 2025, only 80% of female who are eligible for breast cancer screening undergo breast cancer screening. We also know that these screening figures vary depending on several socio-demographic factors. Women without insurance, only about 40% of them are up to date with their breast cancer screening. And we also know that there are racial differences and differences in terms of rurality, in terms of what proportion of women undergo breast cancer screening. For cervical cancer, only 73% of females who are eligible for cervical cancer screening undergo cervical cancer screening. For colorectal cancer, the number reduces to 60%. For lung cancer, that's the most abysmal because it's very, very effective in high-risk smokers, but only 17% of high-risk smokers who are eligible for screening actually undergo screening. And for prostate cancer, it's only 33%. A study done last year showed that 3 in 10, that's 30% of screening age eligible adults in the US were more than a year behind on their recommended cancer screening. So there is a lot we can do to ensure that people are up to date with their screening. But of course, we understand that there are challenges, several challenges associated with screening. And this is one of the challenges with current screening approach. This current screening approach targets just one organ at a time. If a woman wants to go for breast cancer screening, she goes for breast cancer screening, organizes a mammogram. If she wants to go for colorectal cancer screening, that's going to be at a different time, and the screening test looks at a completely different part of our system. So that's a problem, because for an eligible person, for instance, a 50-year-old woman who needs to go for cervical cancer screening, breast cancer screening, colonoscopy, and lung cancer, they have to organize screening approaches at 4 different times. This takes time, this takes resources, this takes money as well. The current traditional screening approach excludes other cancer types. If you're screening a woman for breast cancer using mammogram, you're not going to screen for colorectal cancer. The mammogram would only pick cancers in the breast. It won't pick up screening in the other parts of the body. As a result of that, it's cost inefficient, because again, you have to screen for one particular organ at an individual time, taking time and resources away from work and things like that. Most of the current screening approaches that we have require experienced personnel. For instance, for you to be a colonoscopy, a gastroenterologist has to do it. This is a board-certified physician. There are not many gastroenterologists, and that's why screening in many rural areas are not as expansive as in the urban areas, because there's just not enough gastroenterologists in many of the rural areas. And for mammograms as well, even though you can do the mammograms on the mammogram machines, a breast radiologist still has to read the mammogram information to see whether this is cancerous or not. So yes, it's very expensive as a result of the screening test. And the screening test can be quite invasive. Colorectal cancer screening is done through colonoscopy. You have to first go through some procedure before. Then the gastroenterologist will have to use a colonoscopy to look into it's an imaging procedure to look into the colorectal digestive system. Again, this can be invasive. It can have complications as well. So this brings us to the potential of multi-cancer detection tests. And this is a new buzzword. This started just a few years ago. And multi-cancer detection tests are blood tests that use machine learning to identify markers that may indicate the presence of early-stage cancers in the body. Note the emphasis of early-stage cancer, because again, for screening, we want to be sure that we catch the cancers early, because that's when you can get the best bang for your bucks in terms of prevention. So multi-cancer detection tests, we call them the next generation screening tests. Unlike the traditional screening approaches, you can do one test to capture or pick up as many cancer types as possible. A single modality can also detect multiple cancer types. So it's just blood test. If the cancer has shed its DNA into the blood, that means you can pick up multiple cancers at once. It is cost efficient. You don't need professionals to read the cancer signals. It's non-invasive as well. It's just a blood test. Take a blood test, and then you send the blood for reading at the appropriate laboratories. It integrates AI into the decision-making process. That means it keeps getting refined. It keeps getting better. And again, because it's a blood test, there's huge potential to use it for universal screening, unlike the traditional screening approaches. So this is just a figure showing you the potential bang we can get from the current screening approaches to the multi-cancer detection test, from moving from one organ at a time to one test for all the organs, to looking at several cancer types at one time, the cost efficiency, and also the potential for universal screening. This is from the late media, and you can see that there's a lot of hype when it comes to multi-cancer detection tests. This is various Fast Company. Blood tests can detect more than 50 kinds of cancer. New studies suggest new blood tests can detect more than 50 cancers early. There's a lot of hype in terms of what this can do. But the question is, has the technology been tested? Has it been vetted? And that's a very big question. We all want a test that would pick cancers early. And that's the I mean, that's the gold mine we're all searching for. But at the same time, we must be sure that it's done in a way that will be benefit everyone and it won't cause any harm. So what are the promise of MCD tests? They can identify cancers that don't have screening tests. You remember that I said of all the more than 100 cancer types, only 5 have screening tests. So MCDs can fill in that space and that void. They can detect tumors before symptoms starts, which means at a stage where it's easier to treat, it's less expensive to treat, and treatment options are much cheaper. Because the current multi-cancer detection tests are blood tests, that's very easy to do. They are non-invasive. And again, because you don't need to take time off from work as you do from maybe if you want to go for a mammogram, if you want to do a colonoscopy, there's potential to ensure that everybody, both in the rural areas and also irrespective of occupation and race, have access to this test. However, there are also challenges involved as well. There's currently lack of evidence that they prevent or reduce cancer at the population level. I'm sure you've probably seen, if you watched the last Super Bowl, you probably saw the Super Bowl ad where people came and said, oh, well, I used Grail multi-cancer detection and that helped to pick up my cancer early. While that may work for individuals, we really don't know whether that's going to work at the population level. That requires very stringent clinical trials. There is also the problem of false positive and false negative. And false positive is when the blood test shows there is a positive test for cancer, but upon further testing, there's actually no cancer. And what this means, even though from the ongoing studies, the number of false positive is small, it's about 1%. That means about 10 cases out of 1,000 people who undergo this screening test, they will be told that they have a cancer when they don't truly have any cancer. What this means is that these people would go through additional CT scans, additional biopsies that they don't truly need because the test has told them that they have cancer. And a false negative is when the test says you don't have cancer when truly the individual has cancer. Although the specificity for most of these tests are high, which means they are tuned to pick up more cancer cases than not. So the false negatives are relatively low, but there's the problem with false positives. For some cancer types, the tests that are needed after cancer signal are very unclear and very invasive. Some of the work that we're doing currently shows that the cancer type that are picked up tend to be GI cancers, especially pancreatic cancers, where the workup for pancreatic cancer is very invasive, can be uncertain at times. So that's something that we need to be aware of. And at the moment, the cost of this test, as championed by Grail company, can be very expensive. It's $949, and they're currently not covered by insurance. So that brings us to what are people doing? You can see some of the health systems are already beginning to roll out this test, despite the fact that they've not been proven equivocally to really prevent cancer and reduce harm. So that's a big deal. That's a problem. So yes, this came out just last month. Grail, which is a company that pioneered one of this technology, has been running a trial in England using the NHS system. They recruited over 140,000 people. And if you read the report that came out after the study ended, this is what Grail, the company, this is what is on the company's website. Landmark NHS Gallery trial demonstrates substantial reduction in stage 4 cancer diagnosis, increased stage 1 and 2 detection of deadly cancers, and 4-fold higher cancer detection rate. If you just go with this, you would really, really think that the trial achieved what it was set to achieve with this very positive headline. And they also doubled down by saying they're going to expand their team in the US to really take care of this positive finding so that they're moving on to the next stage. But for the sleuths and for the experienced clinicians and epidemiologists who have gone through the data, the test did not actually accomplish its primary endpoints, and that's a problem. So this is a counterbalance. This is looking at the same data and reporting two very completely different results. You can understand why Grail, so is the hand up? Okay. You can understand why Grail is really touting the positive finding and the success of the clinical trial. It is a multi-billion-dollar public holding company. Once they announced this initial results and people dug a little bit into the data, their share price reduced by about 50% in one day. So they are more inclined to really emphasize the positive findings, even though the findings were not positive. So this is a report that just came out a few days ago. One result, two reactions. And again, this shows that the way the company has really discussed their findings, the way they have interpreted their findings as positive, it doesn't really stand through to test. So we need non-industry funded trials, non-industry funded trial that is not beholden to any financial incentives to really understand how this test really work. So this non-industry funded trials will help us to determine if using multi-cancer detection tests can truly find cancers early and save lives. And it also helps us to understand the benefits and harms in these trials. I'd like to say that this is not a new thing. The current cancers where we have screening, the same process, we went through the same processes to justify those screening tests for population used. These are studies that were funded by not industries, but by governments, and that's the way to do this trial. For instance, the first study that showed that screening mammography work was sponsored by the NIH, involved 62,000 women, and it started in 1973 and was completed in 1986. Several studies out of the Nordic countries, the Scandinavian countries, Sweden, Finland, attested to the utility of HPV screening for cervical cancer. For colorectal cancer, the Nordic colonoscopy trial in over 80,000 people attested to the utility of colonoscopy in reducing mortality and incidence of colorectal cancer. Again, I'm just trying to go through the evidence that high fidelity, robust, reproducible clinical trials provided evidence that screening works. So that's why it's important to go through the same process when it comes to the new technologies of multi-cancer early detection tests. And that is why the National Cancer Institute put together the Cancer Screening Research Network. So this was a very, very competitive process where researchers from all over the country were invited to put together proposals and grants. And the goal of the Cancer Screening Research Network is to conduct multi-cancer screening trials and studies in very diverse populations. I'd like to emphasize the word diverse populations. We know that most of the clinical trials that we do don't really include diverse populations. And the major limitation to that is that findings may not be applicable to populations where the clinical trials are not conducted. So there's an emphasis on ensuring that diverse study populations are included in these clinical trials. The Cancer Screening Research Network would also evaluate emerging procedures for cancer screenings. And of course, the goal again is to reduce cancer burden overall and evaluate how to include these new emerging technologies into risk-based screening. So these are the places where the Cancer Screening Network organized by the NCI are currently taking place. And as you can see, it does a very good job, fairly decent job of trying to represent the whole of the country, ensuring that sites are present all over the country. So there are 8 sites across the country, starting from Fred Hutch in Washington, to Colorado, to Virginia, and Washoe is one of the 8 centers. We also have representations from the Department of Defense and Department of Veteran Affairs. Again, the goal is that at the end of this trial, we'll be able to recruit and enroll people across the country, a diverse study population that would help us to really understand whether multi-cancer detection tests work. The Washoe team is led by myself and 2 of my colleagues who will bring in complementary expertise in terms of what we need to do for the trial. One of the first studies that the Cancer Screening Research Network is undertaking is called the Vanguard Study. And the goal of the Vanguard Study is to help us to learn more about how to use multi-cancer detection tests for cancer screening. The objectives of the Vanguard Study is to recruit and enroll 24,000 healthy participants who are eligible to be screened for cancer across the country, who would assess the feasibility of using multi-cancer detection tests. They would evaluate whether this test can detect cancer early in a way that it reduces cancer-related death. And our goal is that once this pilot trial of 24,000 people is over, that would inform a larger randomized controlled trial that would probably need to enroll more than 100,000 people that can show us the harms and benefit of really rolling out multi-cancer detection tests across several healthcare systems. To be eligible for this study, participants need to be between the ages of 45 and 75 years. They should not have a history of cancer, or if they've had a history of cancer, they must have been cancer-free for the past 5 years. Anyone who is willing to take part in the study must be willing to give blood at 2 time points, both at the beginning of the study and at the end of the study. And they would also allow us to follow them over time for any future cancer diagnosis. If you remember, I mentioned that our goal is to recruit 24,000 participants, and to date, we have recruited a little bit over 3,000 participants. We're racing and seeing whether we can complete participant enrollment before the end of the year, but we know that's very challenging, but that's our goal. Again, what is expected of somebody who participates in the trial? They would reach out to our team here at Washoe, where they would check whether they're eligible for the study. If they're eligible for the study, they would fill in questionnaires asking questions about cancer-related screening habits. They would provide blood sample at the beginning of the study, and they would also provide blood sample 12 months once they start the study. The Vanguard study is trying 2 different MCD tests. One is the Avant test by ClearNote Health, and the second one is the Shield MCD by Guardian Health. And the companies have touted that this test can pick up at least 10 different cancer types. So just a blood test, just one blood test, can determine whether somebody has cancer of the bladder, of the breast, of the colon, esophagus, liver, lung, ovarian, pancreas, and stomach. These are some of the top leading causes of cancer in the US as of now. And the companies have also indicated that they are refining their technologies to see whether they can detect more tests. So potentially, this could be game-changing if it really works. But again, we need to conduct rigorously and robustly tested trials to really ascertain that they can work. So if somebody enrolls in the study, how does it work? So once we determine that somebody is eligible to be a part of the study, we would randomize them into 3 arms. Randomization is done by a computer. Computer generates a random selection and then determines whether the person will go into a control arm or the person will receive one of the 2 blood tests. That's either ClearNote or Guardian Health. Then everyone on the trial will be offered standard of care cancer screening, and they will be followed up over time, over a period of 1 year, to see whether the blood test picks up anything. I mentioned that we have 3 groups. 2 of the groups will receive, their blood will be tested for MCD tests, but the 3rd group the blood will not be tested for MCD tests. And that is very, very important because it helps us to determine if the new screening tools truly improve outcomes compared to the existing established method. The control group also provides us a snapshot of people's cancer screening behaviors without the influence of the test. So while the control group would not be tested, their blood will not be tested for with the MCD test, the information we receive from them being a part of the trial is very, very important, and it will help us to have a reproducible clinical trial. Then the question is, somebody is enrolled in the trial and their test is positive. What's the next stage? The first thing we want to be sure is that there is actually a cancer, a true cancer that is detected. A positive signal doesn't always mean that the individual has cancer. If you remember, I said that the false positive rate is about 1%. That means 10 out of 1,000 people who take part in the trial, who use this test, would have a false positive test. That means they'll be told the test will pick up cancer, what looks like cancer, when there is actually no true cancer. So if this happens, what happens is that we'll then recommend them for more testing to be sure that they don't have cancer. For instance, if the test shows that they potentially have breast cancer, we'll refer them for mammogram images immediately. If the test suggests that they have colon cancer, we'll refer them for colonoscopy immediately so that this can be checked out. And the good thing about being on this trial is that if the test is positive, a siteman nurse navigator will provide support to navigate the person through the healthcare system and ensure that they get the proper care that they need. So in summary, to be on the clinical trial, this is what is expected. To be eligible, the individual must be between the ages of 45 and 75. They must be willing to provide informed consent to be on the study. They would go through questionnaires which they can respond to either on their tablets, on paper, or through an interview with any of our team members. They will provide blood samples that will be tested to see whether it can pick up signal of any cancer detection signal. And then they must be willing to be randomized to any of the 3 MCD test groups. For participants, for anybody who is interested in the study, they can visit our website at WashU, and it's called csrn.wustl.edu. And what you do is you fill out a short form, and based on what you have on the form, research coordinators will call or email to discuss the study with the person, determine if they're eligible for the trial, and then if they are, they'll schedule an appointment for the individual. This is our study team who would reach out to you if you're interested in the study. They've been doing this for a while now. They're very experienced, and they'll be able to navigate you through the process. We have noticed that it can be easier to have group events. So what we've been doing over the last few weeks is to have group events at the Siteman Cancer Center. So what we do is on Fridays and Saturdays, we're beginning to include days of the week as well. We select a very specific time of the day when people can come in. They will answer the eligibility criteria, fill in their forms, and then would also take their blood samples at the same visit. So it makes the experience, it makes it less stressful. So in about 30 minutes, the person is in and out of the cancer center here. They've filled in their forms, they've taken their blood sample, and then over the next 3 days, their samples will be sent to the laboratories where it will be tested to see whether they're positive for any potential cancer case. Again, there's a short video that was supposed to play here, but I don't think it came through. So let me see. Yeah. So if you have any questions, I'm happy to answer them.
Thank you so much, Dr. Toriola, for this presentation. Yeah, so we can go ahead and get started with question. Does anybody have any pressing questions that they want to ask before I ask some questions? You can also type them on the chat and I can ask them. Okay. As we wait for people to think on their questions, I can ask some of the questions that I had prepared. So, one question that I had for you, Dr. Toyota, is so looking ahead, how do you see this new cancer screening changing in the next like 5 to 10 years? And how might that like affect like our community?
Yeah, that's a great question. There's a big push for this to succeed, and because again, it will make cancer screening much easier. That's the thing. But like I said, it's got to be done well. We have to be sure that we're not putting people in harm's way. So yeah, so if this really works, there's going to be a huge change in how we perform cancer screening. I don't know if you're aware, just not too long ago, the Congress passed the MCD Test Act. It's called the Nancy Sewell Act. And what the act does is if an MCD test passes FDA approval, by 2028, that will be covered under Medicare. So again, the this society and everybody is really preparing for what comes next. Again, we need to be sure that the test would really do what they are meant to do.
Thank you. And then we just had a question in the chat, and somebody asked if one did not have any insurance and they turn out to be cancer positive after going through the study, how would that work after you refer them? And then also in the research study, is there any compensation for participating?
Great questions. Yes, research participants are very crucial for our understanding of new procedures. So yes, we appreciate their time and their effort. So they are compensated for their time. There are gift cards of, I believe, $50 or $100 every time they come in for a screening visit. For those who do not have insurance, if they test positive, their funds allocated within the clinical trial to help them navigate the system. The funds may not fully cover the treatment, but it would cover a large proportion of the test that they need to do if they test positive. And there are also other potential options available. For instance, I'm aware that Sightman Cancer Center sometimes has funds available to help people without insurance pay a part of their cancer treatment costs.
Okay. Thank you. And then the next question that we have, is there a geographical location? Is there like a limit for a geographical location for somebody to participate? And then adding into that question, let's say somebody started the study and then they moved out of state. Can they go to another site? How does that work? Or would they stop like the blood tests?
No, there is no geographical location. And in one of the things we really did to ensure that geographical location is not a barrier is you can see how well spread out the centers are all over the country. So even if somebody starts at WashU, they could always, and they move to, and any of these states, they can always continue their follow-up in any of those states. So that's not a problem.
Okay, perfect. And then for anybody, let's say somebody, I guess they're everywhere. Let's say they live in Illinois and Illinois did not have anything. Could they come to St. Louis and still be
Oh,
able to
yes.
participate in WashU? Okay.
They would have
Perfect.
to. One of the things we're trying to do, even though WashU is the main site here, we just activated a site at St. Luke's, Kansas City. So anybody who lives around Kansas City, and they can always go to St. Luke's to do the test. We just got that completed last week, so that's activated. We're also trying to ensure that there are other parts of Missouri, St. Louis, and Illinois where people can do those tests. Like Cox Health in Illinois, that's another place where Anybody who is interested can register for the test.
Okay, perfect. And then the next question that we have, is there a chance that the price of the screening will drop to make it more affordable? So I think you had mentioned it was like 900 and something. So as it becomes more accessible to the public, do you intend for it to drop or decrease? So
in the US, I know that things are driven by supply and demand. For now, Grail seems to be the big player, and for now they dominate and they dictate the price. So hopefully, if some of the other ones we're testing here also work, potentially that could work on reducing price for everyone. I know that as of last year, well, there's been a small reduction in price. Last year, the test was going for $1,000. It's now $9.99. So maybe at some point it will keep dropping by $50 over time, and then it will
yes.
become affordable.
Yes, let's hope so, and hope insurances will soon come on board and start covering it.
That's the holy grail. If this trial that we're working shows that it works, that could be a pathway for FDA approval, and that could be a path for insurance companies covering it.
Okay. And then another question we have is more about this study. So, how many times does one need to participate? I think the age was like 45 to 75. Are they doing the study the whole time, or is it, how does that
So,
work?
okay, yeah. So, again, age range 45 to 75 years. So what happens is you only need to come for study-related visits twice. At the beginning, when you enroll in the study, you answer questionnaires, you provide your blood samples, and then that's it. The blood will be tested. If it's not positive, nothing happens. Nobody reaches out to you. You come back a year after for a second blood draw, and that second blood draw would also be tested. So the physical visits are only twice, at the beginning of the study and 12 months after.
Okay,
And
perfect.
the challenge may be if somebody tests positive, then we have to walk them through the system to get further screenings to rule out the cancer and to determine the tissue of origin and then to determine a treatment plan.
Okay, thank you. And then, yeah, you guys can keep sending questions on the chat as you have them, and then I'll read them out. And then another question that I had was, what message would you want like community members, so the people who came to this forum today, to go home and share with their families or like their friends, their coworkers, after learning everything today, whether it was either about early detection or any of the study? So how would you ask them to go spread out the word?
Yeah, cancer screening saves lives. We need more technologies to pick up cancer early. We're at a pivotal moment where we're conducting a clinical trial that could potentially revolutionize how we screen for cancer. The research community cannot do it alone. We need community members to participate, and we need community members from diverse populations so that whatever we find from this clinical trial will be applicable to everyone, not just those who participate, because that's just how things work out. If we're not adequately represented in a clinical trial, then the findings from that clinical trial may not be applicable to us, and we may not get benefit from it. So if you're interested, encourage people who are eligible to reach out to the team to see whether they qualify to be on the study, and the team will guide you through how to move ahead with the trial. Again, we have some dates that we're recruiting people where they can come in, just come in, drop in into the Sideman Cancer Center into our division, and then we'll walk them through the process.
Okay,
But
perfect.
again, it's always easy. You can go visit the website here and fill out a short form, and our team will reach out to you and get in touch with you.
Okay. And then I think this kind of follows up with my next question. So like us as Vitendo, or even any of the local churches that we go to, do you have any like flyers, or like how can we tell people about the study and they can have like this link, they have a little brief brief information for them to start enrolling? And then let's say for Vitendo, how can Vitendo help bring maybe a group on one of the days that you have in April? Try to have, let's say we have like 20 community members that they want to participate. Instead of them coming individually, how can we just give us any advice how we can group people together and bring them to you?
I think that would be fantastic. If I can work with Vitendo, we can decide, okay, I think that's actually going to be better. We can say, okay, and does any of these days work for everyone? Then I can let the team know so that they can prepare for people from Vitendo coming. Oops, sorry. To get started, download the Google Home app on a phone or tablet. Sorry, that's me. So we can actually make it a day focused on community members, people arriving from Vitendo. So if that's something we can work together on, I'm happy to do that so that we can select any of these days. And if any of these days does not work for the majority, we can find a day that works for the majority. And I can tell the team to see if they can prepare a space for Vitendo members to come on that day.
Yes, I think that would be really helpful. I feel like our community moves in numbers. So when you know you're not the only one going there, you'd be like, oh, I won't be confused. I have somebody, I can bring a friend. I think that would be really helpful. And yeah, we can definitely work with your Vitendo to help bring some participants in. And
that would be fantastic.
Yes. And then Evangeline, do you have a question? I see your hand raised up.
Yes, I do.
Okay.
More on how we can spread this word. So I'm just curious to know, do you have any established collaborations with hospitals already? Because like myself, I do work in a hospital. I would like to know, like, have you guys already established relationships with all these hospitals to, spread the word? If not, how do you intend doing that? Like, let's say if I invite you over to St. Luke's Hospital, how do you come in, or how do you want me to go to St. Luke's and tell them about this trial?
Yeah, that's a great question. So we do have some local hospitals that who DJC has a history of working with and Washoe has a history of working with that we're trying to partner with. But that doesn't mean that we cannot expand beyond our current affiliate hospital. So if there's an opportunity at St. Luke's, we're more than happy to explore that. We're more than happy to come and discuss, talk about it, and then see how we can put together an enrollment at St. Luke's. Like I mentioned, we just went to St. Luke's in Kansas City last week to set this up. So we're more than happy to set it up in other hospitals in St. Louis. So please reach out to me and then we can take the conversation further.
Okay, perfect.
Okay.
And then we also had a question asking you, do you have any resources out in Seattle or like a hospital that somebody who lives in Seattle can reach out to kind of pass that out to the community in Seattle?
Yeah, that's going to be the Fred Hutch Cancer Center in Seattle. I'm happy to send that to you, Jeff, so that they can pass that around as well. So yes, there's the Fred Hutch in Seattle, who is also a part of the trial.
Mm-hmm. Thank you. Any other questions? And then this is one. Oh, I see one. Oh, yeah. So Dr. Modoni said, the idea of a single test looking for so many cancers at once sounds very amazing, but it's also a little scary. So how long does it take for you to get the results?
I agree with those concerns. And the tests are supposed to be done in 3 days. That's the standard procedure. And the ones we've done so far, once the blood gets to the company, they tend to get back to us in 3 to 4 days. So give or take a few days, 3 to 5 days, you should be able to get the results back.
Thank you. And then is there any support that is given to a participant as they're waiting in that waiting period if they're like anxious?
The participant can always reach out to members of our team to discuss their fears, and we can just talk them through things they can do to allay their fears while they are waiting for the results. What we've seen so far, about 4 to 5% of people who provide the blood test positive for a type of cancer. So that's 4 or 5 out of every 100. That's so far. The more we go on with the trial, that number can change.
Okay, and then I just had, there's one more question. Oh, this one they're asking, how do you request a doctor for the test and how often?
How do you request a doctor for the test?
Yes, I think
because this is a clinical trial, you don't need to request a doctor for the test. You come here, would take your blood samples and we'll send it on your behalf to the companies that will do the test. So you don't have to do anything. If you want to do it outside the clinical trial, I think Mercy and some other hospitals are offering the Grail test. It's called the Galleri. But I would really not advise people to take it up as a regular cancer screening test yet until we have the evidence that it really does work. So, and this is why we're doing this.
Yes.
Great questions. I love them. Please ask more.
And then another question is for students who want to join the cancer research, what resources do you have available for them? I don't know if this is for students to join to work or to join to participate.
Unfortunately, unless the student is 45.
It's 45. I think maybe they're asking more for the student to join, maybe to work in the cancer.
Okay. Yeah. And send me an email. Let's see if there's a space for you. Feel free to send me an email and I can talk to you and then we can see what options, opportunities are available.
Yeah, and we'll share his email on the after the forum in case any of us did not have that. And then, yes. Do you want to ask your question, Evangeline?
Yeah, I don't know if you said something about that, but let me ask. I think I heard you talk about referring people to further testing if it was detected with your testing. Is that correct?
That's right. That's right.
Okay. Did you talk about I would like to know more about the specificity of that initial testing.
The specificity of the two tests that we have, the specificity is between 95 and 99%, which is quite good for a screening test. So again, let me see. So far, out of the 3,000 people that have been enrolled into the trial, we've had about 20 to 30 positive cases, and all the 20 positive cases have been referred to for further testing. Some of them have been false positive, just, okay, well, it found something, but it's not a cancer. But there's a lesion there, but it's just not a cancer. It could be a benign lesion. For instance, pancreatic disorders has been one of the top leading things we've found. And so they're not pancreatic cancers, but they're IPMN, which are precursor lesions for pancreatic cancer. So the patient then undergoes yearly screening with their family physician or their gastroenterologist. So so the specificity, as you mentioned, it's about 95 to 99%.
Okay, thank you.
And then another question that we had, so I think this more falls on, other than screening, what can people do to be more proactive in preventing like cancer? And this can be like what foods, how to take care of their diet, their health. Do you have any advice in all of that?
Yes, that's another great question. Yes, there are several things we can do to ensure that we don't get cancer. Of course, screening is number one. Screening has been one of the leading ways by which you can prevent cancer. But if you're not of the screening eligible age yet, there are several lifestyle choices that you can take to reduce your risk. I want to emphasize that again is risk reduction. There are times when we don't know what causes cancer, and some people just have cancer even when they've lived very healthy lifestyle. But some of the things that you can do is don't smoke. If you smoke, stop immediately. If you smoke and you stop smoking, your risk of cancer reverts back, your risk of non-cancer reverts back to normal within a few years of smoking. Um, Make sure that your diet is one that is very high in fiber, vegetables and fruits, and low in red meat and other carcinogenic exposures. Be physically active. We know that several studies have shown that 30 to 45 minutes of physical activity 5 times a week reduces the risk of many types of cancers. Maintain a healthy weight. Being obese increases the risk of 13 different types of cancers. Even if you're overweight or obese, once you get your weight back to normal, you already put yourself at an advantage of reducing your risk of developing cancer. Um, Ensure that you go through your screening, as like I mentioned, regularly. Um, we also know that sometimes sexually transmitted infections such as HPV increase risk of cervical cancer, head and neck cancer. So again, just to be proactive in preventing sexually transmitted diseases and other things that may increase the risk of HPV-related cancers.
Perfect. And then I think as Jeffrey had started this meeting, so a lot of us might know somebody who has cancer or might need to go get either a test to check in. How can we be of like support to either friends, family, or like encourage people who are at the age to go get screening, who have a fear or like they're scared of cost or they just don't want to know just yet?
Yeah, and that first step is always very crucial. Yes, a lot of people don't undertake screening because of the fear of diagnosing cancer, but I would like to say it's better for the cancer to be picked early, like I mentioned earlier. And we've had a lot of advances in treatment in managing cancer. Like if you diagnose breast cancer in stage one, you can be sure of a cure. Like I can guarantee that. Stage one breast cancer, you're going to be cured. That's the truth. Stage four, your possibility of being alive in 10 years reduces significantly. So while a diagnosis of cancer is definitely anxiety inducing, it's better to go in for the test, discover it early, and then start the appropriate treatment. It's not easy, but I'll rather encourage people to get tested, pick up the cancer early, and then go through the journey with the support of family and friends of embarking on the treatment journey.
Thank you. And then, oh, can you speak more to HPV? There's a lot of conflicting information and probably some cultural and religion issues around this. The idea that this may signal endorsing like early sexual activity. So, what do you recommend, especially when when giving cultural and religious attitudes?
That's another great question. Yes, the leading cause of cervical cancer in the last 30 years has been HPV, that's human papilloma virus. It's a virus that is usually contracted through sexual activity. It Vaccine against HPV practically eliminates cervical cancer. I mean, it's unbelievable. It eliminates it. Right now in Australia, there is no more pap smear testing. There is no more HPV screening because they've almost virtually eliminated cervical cancer as a result of HPV vaccine. So while some people may worry, I'll say the fear may not be justified based on the data. It prevents cervical cancer. And also, we also know that some of the oral pharyngeal cancers are due to human papilloma virus. So in addition to preventing cervical cancer, it could actually extend to preventing some oropharyngeal cancers that are HPV related. So yeah, and I'd like to say that HPV vaccine does not prevent other sexually transmitted diseases. So I know that there's been that tension that, okay, having an HPV vaccine is likely to make a young person more promiscuous. There's no data to support that because it only prevents against cervical cancer. It doesn't protect against gonorrhea. It doesn't protect against syphilis. So there's no reason for somebody to be increasing more risky sexual behavior just because they've had HPV vaccine.
Mm-hmm. And then another question is, usually they hear that a lot of things like either using microwaves, putting on smartwatches, and all these other things can cause cancer. Like, what are any of your studies or any of your knowledge? What can you tell us about this?
Yeah, we can spend the whole day here talking about those. Yeah, I understand. Yeah, people have fears, and those fears are natural. And we want to be sure that we're doing the best to protect ourselves. But there's no data to show that microwaves and things like that cause cancer. One that I've had conversations with people more recently is that mammograms, which is used to detect breast cancer, may increase the risk of cancer. That's also not true. The analogy that I like to give is that the radiation from mammogram is much lower than the radiation from flying, from being in a plane. So think about it. You're not going to say you're not flying just because of the radiation exposure. So the same thing, you're not going to say you're not going to do your mammograms because of the very, very small amount of radiation that you're going to get from there and overlooking the potential benefit. Yeah, I understand there's a lot of information out there. There's a lot of things that are not true. There's a lot of misinformation. And that's why it's good to know what sources of information to trust. And maybe in another forum, we can talk about that. And given everything happening now, there's some things that I would be very wary about trusting this. But that's another forum entirely. But yeah, the things that you have mentioned, there's no indication that they increase the risk of cancer. And vaccines do not cause autism. The cancer vaccines do not cause autism.
Mm-hmm. And actually, backing up on that question, do you have any like websites or books or any people where people can learn like the actual and accurate information on cancer or any other like diseases? Because I feel like the internet, you can find anything and everything you're looking for, or everybody's an expert. So do you have any like resources where people, if you have any questions and we can't have a forum like this where somebody can go and read, learn, or watch?
Yeah, I'm happy to share some of those resources. There are a lot. Before January 2025, I would have said anything you find on CDC, you can trust it, but not now. Before January 25, I would have said anything you find on the HHS Human Health Services website, you can trust it, but I wouldn't vouch for that now. Again, I'm happy to share resources that would really um, guide you on saying, okay, these are the established causes of cancer. These are the things that are backed by evidence, not some spurious things that some snake oil men are trying to promote.
Yes. Mhm. And then another question we had was, how much does the test cost with the trial? Which I think there wouldn't be a cost.
Now, if anybody
Mhm.
taking part in the trial would not pay for the test, it's free of charge as part of the clinical trial.
Mm-hmm. And then back to the HPV, there was a question, is there an age limit to get the HPV?
There is an age limit. I don't have that at the back of my head now, but there is an age limit for it.
Mm-hmm. And I think that's all the question that we've gone through in the chat. Do we have any other last minute questions? Dr. Maloney asked, how long is the trial? And if you're in the control group, will you get to move to the test group at the conclusion of the study?
An individual is on the trial for 12 months. And no, it's not a crossover trial, so you don't get to move over to the intervention group if you're on the control arm.
And just to make sure, you wouldn't even know if you're in the control group because it's randomized. You would
It's
just think
randomized, so you wouldn't know. You wouldn't know. Yeah, you would not. Yeah. It helps us all to keep things blinded so that that knowledge doesn't come into how you analyze the data.
I think that looks to be the end of our questions. Thank you so much. This has been very informative. I can say that for myself. And I think that's also for everybody else. So hopefully we can have more of this and we can bring you more people to come to the tribe.
Fantastic. Well, it was fun talking to everybody. Again, if you have questions, Sally, Jeff know how to get in touch with me, and feel free to send, and I'll be happy to answer any questions you have.
Yeah, I shared his email on the chat and I can still share it again. And Jeffrey will also share as we send a thank you email to all our attendees. We'll share the email, and when Dr. Toriola shares us the resources and stuff, we'll make sure everybody receives them.
Fantastic. Thank you all for coming.
Yes. Jeffrey, did you have any last minute words? Or Elizabeth?
I don't think, I'm not sure if Jeffrey will be able to say a
Can you
word,
hear
but
me?
we've seen. Thank you. Yes.
Yes,
Okay,
we can
go
hear
ahead,
you.
Elizabeth.
All right. We want to say thank you so much, Dr. Tudzi, and thank you so much, Sally, for facilitating. Thank you so much for the information, and we'll be sure to send to everyone. And I'll hand it to Jeff.
No, thank you so much. I appreciate Sally and Dr. Toriola for that great information and great resources. I think what you mentioned is also to be careful on the information that we feed ourselves. So getting the right information is very helpful, and when you know the right thing, it's also good to share with others. When it comes to the cancer, like I mentioned at the beginning, it's something that I really take it very seriously. Like I mentioned, I lost my dad when he was very young, at the age of 50, and my mom was also sick, and she went through the treatment. If there is anything that I really would want to, I don't want any family to go through what we've gone through as a family. And if anything that we can do to do that early detection and do the treatment, and if possible, the best we can to prevent it, which means, like you mentioned, is just also to take care of some of the information that we are told to do, of being able to do that and take precaution. Don't wait to say, oh, I wanted to make sure that it wasn't true. It wasn't scientifically proved that I can do this. But until I always say, we just came from a meeting at DC, and one of the guy who was doing a research, he's been given a lot of recognition. He said, for 40 years, I spent 40 years to prove something that was obvious, clear, something that was obvious. Sometimes wait until it's scientifically proved, but there's some enough evidence that tells you there is something going on. Even now, what we're hearing, there's a lot of evidence. Is on now we have to go through the process. But when you hear something is there, and some data shows that it shows there's something, but we have to go through the process. So when you hear some things you need to do, let's go ahead and take care of that. And we probably through doing that, we may be able to save a life. I think Elizabeth has shared there is some event coming up. March 21st, we're inviting all the mentors and the mentees to join us at Deaconess Foundation. We have a great speaker and great panel that will be there. We'll be diving deeper on the things that we all need to know, especially for those who are in this country. You have a young person in the high school, in college. We invite you to be part of that part of that meeting. And if you have not signed up, please go ahead and sign up. If you know somebody that could benefit, please share that information and they can be able to join us. Then on March during the spring break, March 25th, we have youth mental health first aid. This is for any parent or anybody who is working with a youth, either a teacher or you have a youth program. We invite you to join us for a youth mental health first aid. And then on Thursday, the 27, 26, 27, 28, we will also do the teen mental health first aid. Anybody who is 14 to 18 years old, we invite you to have them register. It's a free program, but a life with an impact that will have a great impact in their lives. April 4th, we have adult mental health first aid, and this is across the board. Anybody who is 18 and above, please register to attend the session. Thank you so much for all the good work you're all doing and helping to pass the message, but also helping to keep our communities safe, community strong and healthy. We appreciate you all. Thank you, Dr. Adetunji. Thank you, Sally, for coordinating this.
Okay.
Thank you so much.
Bye.
All right, have a good night.
All right. Take care.